My name is Jeremy Ringewald. I'm a pediatric cardiologist specializing in interventional cardiology for both children and adults with congenital heart disease at St. Joseph's Children's Hospital and St. Joseph's Adult Hospital. I think you can divide up kind of the main things we do into procedures we do to close extra connections in the heart that are unnecessary or hurtful to a patient, and to open up things that are narrowed in some way. So the things we do for closures, the main diagnoses and problems we can take care of with that are the majority of atrial septal defects these days can be closed without an open heart operation, and the vast majority of patients with what's called a patent ductus arteriosus, or an extra artery connecting the main pulmonary artery with the aorta. Those are probably the two most common things we do. There's other extra connections between the coronary arteries and the heart. Occasionally, some of our patients with holes between the bottom chambers of the heart or a ventricular septal defect we can close without surgery. And that kind of encompasses the majority of those sort of things. In terms of opening things up, that involves ballooning open valves that have blockage to them. So they're congenitally malformed valves leading to pulmonary valve stenosis and aortic valve stenosis. Those are far and away the two most common valves that we balloon across that valve to make that valve open and close better. In terms of narrowings, the narrowings of blood vessels we can take care of include narrowings in the pulmonary arteries, the lung arteries, both where the main vessels are and out where they branch into the lungs. Narrowings of the aorta we can take care of with both ballooning and or stenting. That's called coarctation of the aorta. And probably the last thing and least common are narrowings in the veins that drain to the heart, or the systemic veins like the superior vena cava or inferior vena cava. All of those problems used to be solely surgical problems, and now for the vast majority of our patients, those are actually patients that can avoid surgery by a transcatheter procedure of some sort. Additionally, kind of the newest stuff we've been able to do is for selected patients with a dysfunctional valve in their heart, and at this point it's mostly for patients with a dysfunctional pulmonary valve, patients that have already had surgery and a surgeon to replace that valve. When that valve down the road develops dysfunction again, we can replace those valves in many of our patients, again, without surgery as well. So those are kind of the main closing things, opening things, and selected patients we can replace valves. And the vast majority of them are performed in a heart catheterization lab, which is a procedure room similar to an operating room, but the focus in a cath lab is on your imaging to guide what you're doing, and the procedures are all done by going through the blood vessels to the heart, and that's going through the blood vessels near the hip or the blood vessels in the neck. Additionally, and occasionally, we do some procedures in collaboration with our surgical colleagues, and in those procedures called hybrid style procedures, what we do is part of the procedure is the surgeon does. So in one instance, the surgeon would open the chest and actually give us access to get to the blood vessel or part of the heart that we need to fix with a transcatheter technique, give us the access into the heart. So occasionally they'll put a tube or what's called a sheath directly into a main pulmonary artery to allow us to do both angiograms and then to place a stent in a patent ductus arteriosus. That's another procedure. Those are hybrid things. And those are some of the things that we're starting to do collaboratively that are kind of surgical and kind of interventional at the same time. So the main advantages of a less invasive procedure are in terms of the recovery time from the procedure and the amount of time after the procedure where the patient has to really take it easy because there's a wound to heal. The majority of things we do go through a very small incision in the leg, and that small incision is smaller than a pen, sometimes as small as a cocktail straw. It's very small. Because of that, there's less invasion, and there's less of that part of the body to heal in the recovery from that intervention. That in general is kind of less stress on the whole patient, head to toe, but it also allows them to get back to their normal activities of life in a much shorter time period. To give kind of one example that's pretty common, we very commonly close an atrial septal defect with an implantable device. Okay, that procedure, if we can do it with an implantable device, the procedure takes about 2 hours. We're in the recovery room within those 2 hours. We stay overnight one night. We go home the next day after the procedure, and we're really back to school in 3 to 4 days. So we have a very short turnaround time in terms of getting back to kind of normal daily activities. If that patient had an open heart surgery, they'd be in the hospital more like 3 to 5 days and wouldn't be back to school for at least a couple of weeks. And then after that, they're not back to kind of full activity for another month or so after that, just because you have to wait for the chest to heal from where the surgeon went in to do their operation. So for our patients that need an operation, that's what they need done and that's what they need done. But for patients in whom we can offer a less invasive alternative, the recovery time is just remarkably shorter and therefore kind of less stress on the entire patient and entire family.